Hi, my name is Swaminathan Kandaswamy. I'm a research faculty at Emory University. I'm happy to present our work on identifying barriers to seasonal influenza vaccine uptake in a pediatric inpatient healthcare setting after implementation of clinical decision support. This work was supported by a grant from the Agency for Healthcare Research and Quality. I would like to thank my co-authors. I would also like to provide disclosure on one of our co-authors, Dr. Evan Orenstein, who has equity in Phrase Health, a clinical decision support analytics company. He does not receive any direct revenue. Influenza as a disease has a very high global burden, and it results in approximately 374,000 hospitalizations in children less than 1 year old globally, and also 870,000 hospitalizations in children less than 5. The Center for Disease Control estimated that there were 477 deaths related to influenza in children during the year of 2018-2019 within the US. Vaccination, as we know, can prevent millions of these healthcare visits, and it can also reduce deaths and ICU admissions and other outcomes related to hospitalization. However, the uptake of influenza vaccination is poor, and only 63.8% of the children in the US were vaccinated in the year 2019-2020. 42% of hospitalized children were found to have had a missed opportunity for prior vaccination. And it is critical to utilize all opportunities, including hospitalizations, and not just rely on routine primary care or healthcare visits, because for some people, especially those who are socially disadvantaged, they may use the emergency room or the hospital as their sort of primary clinic, and they may not have a primary clinic themselves. So we provided influenza vaccination for hospitalized children, and we had a clinical decision support system to promote flu vaccine uptake, and it increased our vaccination rates from 14% to 31%. However, we did find there was a gap between vaccine orders and vaccine administrations. To sort of give you a brief background on the clinical decision support that was used in the system and the workflow within our health system, patients who got admitted to the hospital spoke with the nurse, and they answered questions about flu vaccination during the nurse admission questionnaire. And then there was also a system check for flu vaccine eligibility, where the system checked against the state registry system to see if the patient had already received flu vaccination in the current season. Based on the answers to the flu admission questionnaire and the system check, the physicians in their order set would either have a pre-checked order for vaccine if they were eligible or not. And then the physicians can decide to have the flu vaccine order along with the admission orders. And then the nurse would acknowledge the order, and they would get consent from the patient or the family, and then do the administration prior to discharge. So here is a screenshot of the nurse admission questionnaire, which the nurse fills out at the time of admission, and it specifically asks questions about if the patient has got vaccine for the season, and or if they are willing to get it. We also used a presumptive opt-out strategy, so that by default, they would sort of be included for vaccination, and unless they have sort of indications for anaphylaxis or specific refusal to vaccination, then they would be eligible for vaccine administration. And this is a screenshot of the admission order set, where the physicians would have pre-checked orders for influenza vaccine, and it would also have sort of links to references for questions on if it was safe for children with certain conditions to get the vaccination. Also, they had links to the state registry system to confirm vaccination or any prior vaccinations. So the aim of the study is to actually find why there was a difference between rates of vaccine ordering with the providers and actual delivery and administration of the influenza vaccine. So we did interviews with frontline clinicians, both nurses and ordering providers. And we also did content analysis of the orders that were canceled by the nurses who at the time of cancellation had to put in comments for order cancellation. So we found a number of barriers through the interviews. First, the nurse found that there was a culture to defer orders to discharge. So they wanted to push the vaccine administration to the time of discharge, and they thought that that was sort of what was expected and didn't want to give during the time of admission when the patient is treated for other reasons. And then the nurse also didn't feel empowered sometimes to talk to the families about influenza vaccine. And this happens due to sort of some reasons, including one, the nurse is not knowledgeable or don't know all the resources that are available to them to answer patient questions about flu vaccination, or they didn't know if it was their place versus the physician's place to have this conversation. And also nurses felt that they cannot follow up on orders regularly because the pending orders, once they are acknowledged in their MAR, which is the medication administration record system, it might fall off their radar and they may not look at it at a later time easily. We also identified that there may be low supply of needles in certain areas within the hospital. And the nurses also said that once the orders were pushed to discharge sometimes, it's easy to miss the vaccine administration at the time of discharge because of how the hospital is at the time of discharge and due to hectic discharge processes. Also, the influenza vaccine conversation with the patients did not happen early during the admission. So when the providers went to meet the family at the time of admission, they didn't know if the patient was eligible. And so sometimes they didn't know if they needed to have conversation with the patient regarding influenza vaccination, while they may be busy with conversations for the reasons the patient are getting admitted. Also, when the providers put in the orders, they didn't feel like they had an easy way to follow up on the orders to see if those got administered. And then when we look at the contents of the comments in the orders that were canceled, we can see a large proportion of them were canceled automatically. That means nobody canceled the order, but the system canceled it automatically because the patient got discharged without getting the vaccine administered. And then we also had a large number of cases where the patient refused, and some of the cases where they wanted it at the time of discharge and not during early during the admission process. And some of the patients mentioned they didn't want to get vaccine done while they were sick, or they preferred to get the vaccination done while they were at the primary care physician's office. So if we look at the total number of sort of reasons for the cancellations from the comments from the order cancellations, we can see that 1/4 of these administrations were direct refusals, and nearly 1/4 of the cancellations were due to them stating that they already received the vaccine, even though our system integrates with the state registry system. Some of the vaccines in maybe like the pharmacy may not be captured adequately in the state registry system. And so there is a mismatch in how we identify patients who might be eligible. Even if we consider like both of these groups to be people who we may not be able to reach out to for actual administrations, we still had opportunity with nearly half of the gap between vaccine orders and administrations for actual administrations. And this involves requirement to help with nurse empowerment so that they can have these vaccine conversations with the family, and also provide them with resources that would enable them to have those conversations, and also optimize the workflow so that the vaccine uptake can be smooth, and not necessarily be at the time of discharge to avoid any hectic or misses during the discharge processes. We also found a number of issues related to um, lack of system support for follow-up, and we have started implementing sort of more decision support around sort of indications for the status of vaccine orders, so that nurses and providers can follow up with the patient if they had questions during the admission and try to increase vaccine uptake. Though we have started implementing some of these, the results of the newer interventions are yet to be analyzed. The study is limited by the analysis of barriers to one health system, and it's also limited by small sample size due to only 1 year, and also due to interviews with only 6 clinicians in total. So if we can expand these analysis to other health systems, we might be able to get more generalized learning and improve vaccination uptake. If you have more questions regarding this study, please contact me at swaminathan.kandaswamy@emory.edu. Thank you for your time.